Okay, guys, now let's talk about specifically classifying opioids. I do not expect you to know these names. Honestly, gun to my head, I probably couldn't tell you what the names of these are. But knowing kind of which classifications these drugs fall into really help us figure out some of the agent-specific factors. So, for example, morphine and codeine. Codeine is a prodrug of morphine. So giving somebody codeine, they metabolize it through a 2D6 and it becomes morphine. Um, the agents that are very similar or semi-synthetic include heroin, hydromorphone, and oxycodone. The partial mu opioid is buprenorphine, and so on and so forth. So let's talk about that a little bit. So your natural opioids are morphine and codeine. Remember, codeine is just a prodrug of morphine. Phenanthropines, or heroin, hydromorphone, and oxycodone, are semi-synthetic along with buprenorphine. The rest of these agents are considered synthetic. The reason this might be useful is if somebody has a true opioid allergy, such as an allergy to morphine, using some of these other agents may be appropriate, including the synthetic agents. Additionally, we can classify opioids based on their mu receptor activity. So you have agonists. So these are most of your opioids. Pure mu opioid receptor agonists, and a good example of this would be morphine. It's kind of the classic. Versus partial agonists will have a high affinity for the receptor. They'll hold onto this receptor tight, but they don't have a lot of activity at the receptor. That does look kind of like a person, but this is like the mu opioid receptor. This is your antagonist, agonist kind of situation, or partial agonist situation. Your mixed antagonist agonists are ones that have actions at different actions at different receptors. So you do have other types of opioid receptors. You have the mu opioid receptor, the kappa opioid receptor, and the delta opioid receptor. So these are agents that may have agonist effects at the mu opioid receptor, but antagonist effects at other receptors. And then pure antagonists. So have affinity, but no activity. So this is naloxone. So let me just show you guys here what this looks like. So your partial and mixed include your buprenorphine, your morphine deliverants, such as morphine derivatives, and your benzomorphins. The rest of these are pure mu opioid receptor agonist. And again, your only antagonist is naloxone. Now let's talk about some agent-specific characteristics. Once again, you guys have your stars for your top 300 drugs. So I really do need you guys to know everything on this slide because it is quite important. So, for example, morphine. It has the highest amount of histamine release. There's almost an 80% risk of pruritus while you're taking morphine. In patients with renal insufficiency, you can have increased levels of the morphine 3 gluconate, which has excitatory effects or the depressive effects, but it can cause increased risk for accumulation and overdose in renal insufficiency. So just keep that in mind with your little beans here. Codeine. The biggest problem with codeine is the CYP2D6 polymorphism. Rapid metabolizers will have increased morphine because it is a prodrug concentrations. This is one of the reasons why it's no longer used as an antitussive for children, though it can be used as an antitussive for adults. Hydromorphone has a relatively high potency versus codeine, which is low potency. And it does have a metabolite, H3G. Mostly you just have to monitor your dosing whenever you're using hydromorphone. It's less important as far as like a specific contraindication. If you have somebody with renal disease, definitely avoid morphine. Hydromorphone, you just try to start at a lower dose. Very similar to oxycodone. Hydrocodone primarily comes in formulations with Tylenol, also known as Norco. Previously, you had Vicodin, and you still hear it used, but technically Vicodin was 500 milligrams of Tylenol, with hydrocodone as opposed to 325. Vicodin and Lortabs both got discontinued off the market. Lortabs, I think, had 650 milligrams of Tylenol in them. They were discontinued off the market because of the risk for Tylenol overdoses. Oxycodone does come in formulations with Tylenol as well. You do have, it is a prodrug just like hydrocodone. So you can see that through those metabolites. Buprenorphine. Buprenorphine is a partial, if you remember. And I'll show you a picture to help you figure this out. But what you need to remember is that it has low activity at the mu-opioid receptor. It has a long duration of action with slow dissociation from the receptor, and it's used in the treatment of opioid disorders. You have now this X waiver, so pretty much anybody can prescribe it. It does come with a naloxone combination, and this is an abuse deterrent. Because if you try to crush it up, let's just take a moment here. Whenever we were talking about naloxone, we give it in the nasal formulation, or we do it injectable, right? The reason is because naloxone has poor oral bioavailability. So when we use naloxone with drugs, we use it as an abuse deterrent because if the patient takes it as they're supposed to, the naloxone is not going to do anything. So if you take this buprenorphine, it's actually technically not PO, it's technically sublingual. Sublingually, the naloxone won't do anything to the patient. It's just kind of a extra additive there. Versus if you take it as an IV, like if I crushed it up, tried to inject it, you would go in immediate withdrawal because now the naloxone is available. Similarly, we do use it as an abuse deterrent in other agents, like I was talking about before with oxycodone. There is a transdermal version of buprenorphine for pain. It's a very, very low dose. Now, moving on to meperidine. What I want you to know about meperidine is that it's no longer really used for pain management. Per the APA, the American Pain Association, it should not be used for pain. It primarily gets used for shivering. And the reason is because of this toxic metabolite that can accumulate in renal dysfunction, normeperidine. So overall, if you see meperidine as an option on your exam for a therapeutic choice, just say no. Also in real life, just say no to meperidine. Again, only used for shivering, and that's like perioperative shivering. Methadone. Methadone is the other drug that is used for opioid use disorder. So buprenorphine and methadone are both used for this. Methadone, you can only get at a specialty clinic. So you have to go to a methadone clinic. Buprenorphine, you can prescribe. Well, let me just say this. Sorry. That's kind of a false statement. Methadone, you can get at a regular pharmacy. But if you get it at a regular pharmacy, you can only use it for pain. Versus, if you are using methadone for opioid use disorder, you have to go to a specialty clinic. Buprenorphine, you can get without going to a specialty clinic, no matter if it is for pain or opioid use. So if you are using it for dependence, you have to go to a specialty clinic. If you're using it for pain, you do not. And you can get it at a normal pharmacy. You guys probably have methadone at your pharmacy. If it is specified that they are using it for opioid dependence, then you cannot use you have to refuse the prescription. Methadone is extremely long-acting, like buprenorphine, and that's one of the reasons we use it for opioid use disorder. It's taken once a day usually. It does have some NMDA and monoaminergic reuptake inhibitor action, so it does work on a couple other receptors. That's just something to keep in mind. Sometimes we might use it for neuropathic pain for that reason. Amongst these synthetic agents, so these are like the pure synthetic agents, methadone is as well. Fentanyl probably is the most commonly used. It comes in a transdermal patch and is used for anesthesia. Sildenafil and alafentanil are both used for anesthesia primarily, but you will see fentanyl used. It can also be used as like a lozenge for head and neck cancers. So I put this slide in here so you guys can see the difference between methadone and buprenorphine as far as how they work. So methadone is a pure mu-opioid receptor antagonist. So once it gets onto this receptor, it's a full agonist and it will generate its effect. Buprenorphine, whenever it hits the receptor, though it binds with a high affinity, so that if I did try to take an opioid while taking this buprenorphine, it just bounces off the receptor and doesn't really do anything. While it's holding onto this receptor so tight, so just think so tight, it's holding on so tight that nothing else can get on the receptor, it's only giving limited agonist feels. So that's why it's a partial agonist antagonist. Now, naltrexone, or also naloxone, are pure antagonists. They just block all the effects. Some other agents that we want to consider: buprenorphine, or buporphanol. Sorry, I apologize. We were just talking about buprenorphine. You can see all these have different effects on mu-opioid receptors and such. You can see some of them are receptor agonists and some of them are receptor antagonists. Note which ones have the cardiac side effects and which ones have the psychometric side effects. That's the biggest thing you need to know here. Levorphanol is serotonergic, so you do want to avoid it in patients that have MAOIs as well. Increased risk for serotonin syndrome. Our final set of agents include tramadol and tapentadol. These agents are weak or moderate mu-opioid receptor antagonists that work on serotonin and norepinephrine, so they're kind of in their own class. Tramadol is technically a morphine or codeine analog, and if you do have CYP2D6 polymorphisms or drug interactions with CYP2D6 inhibitors, that is something that we would want to monitor. It can lower your seizure threshold and cause serotonin syndrome, just like tapentadol. Now that is the end of our mu-opioid receptor agonists. In class, we will do some example cases and do some example calculations. I can't wait to see you.